Hello, and thank you for the invitation to speak at PedirhythmX. I've been asked to talk about lead management and extraction in adult congenital heart disease. Since the title talks about lead management as well, I thought I'd focus more on that and less so on extraction in general, hopefully avoid situations like this in the future. As a quick side note, I will not be talking about epicardial leads and their management long term. Now, all of you know who take care of adult congenital patients, we often think about their management in the long term, not just getting through the next 5 to 10 years, but really what can help them get through the next 40, 50, 60 years of their life. Often these decisions start early on for them, a lot of times in childhood and into adolescence. A good example, admittedly a little bit extreme, but a good example are cases like this, where it's quite interesting and technically challenging to be able to put devices in neonates, who are 2.5 kilos in size. But often as a field, sometimes we're so preoccupied with whether or not we could, we didn't often stop to think whether or not we should. So I think our job when we take care of congenital patients is to keep calm and think long term. Part of that is looking at the type of leads that we use. There's a lot of literature on the different types of leads and their durability. This one from Emory looked at 6,700 patients, 9,800 leads, and they compared them across companies. I looked at Medtronic Capture Fix, Boston Scientific Fine Line, and then Abbott's family of Tendril leads. They found that as you can see in the blue and black lines on the graph there, the Tendril leads are more likely to fail compared to Medtronic and Boston Scientific leads, and they think this might be due in part to the special opt-in installation that some of these leads use. Thinking not just about durability long-term, but also thinking about how long leads handle under extraction is also very important. Though fine lines we know can last a long time, I think they're also more likely to break when it comes time to extract them. This study here looked at 250 patients and over 500 leads and found that lead age, passive fixation leads, and co-radial leads, so leads that are designed in a single helix rather than two helixes wrapped around each other, were more likely to break. And unfortunately, this encompasses a lot of fine lines characteristics. I also personally think that fine line leads, locking stylets don't really hold on to them when you put them in, which also can make them challenging to extract. So even though I love fine line leads in terms of implanting them, they're very easy to manipulate and put in. I kind of wonder whether or not I'll regret that decision in 10 or 15 years down the line when it's time to take them out. Used more commonly in pediatrics, but much more so in the adult population now are the 3830 leads. They're used more commonly for his bundle leads and left bundle area pacing leads, with the 40% increase in their use since 2016. They work really well. Their durability is great, as you can see from this graph here. But Jeff Moak's study also showed that they have slightly higher thresholds. Not a lot. They estimate that over the course of a generator, they could decrease battery life by 0.6 to 0.7 years. They also found that these leads, the select secure leads, are more likely to dislodge over their first month after implant, that overall complication rates while using these leads compared to conventional leads was not very different. These leads also cause less issues within the veins and the heart. This study here looked at 130 patients, 65 select secure leads, 69 other leads over a 9-year period, and found that select secure leads were much less likely to cause AV valve regurgitation, and also less likely to cause SVC or innominate vein narrowing over time. They also tend to hold up well under extraction. Given their luminous design, they have quite good tensile strength when you're pulling on them. This study here done in the UK was great. They looked at extracting select secure leads versus conventional leads. 57 patients, 22 select secure leads, 35 conventional leads. All of these patients had congenital heart disease. Of the 22 select secure leads, 9 of them came out with gentle traction alone, 7 of them needed polypropylene sheaths, and 6 needed powered sheaths. This in comparison to the 35 conventional leads, where only 2 of them came out with manual traction, and a lot more needed complex extraction, which is defined as either needing a femoral approach and or having a partial lead left behind. In terms of ICDs, this is well known and does not have to be rehashed all too much. This meta-analysis here looked at 18 studies, 138,000 patients, and found that there was no obvious benefit to using a dual coil lead over a single coil lead. And of course, there are issues with dual coil leads when you come to have to take them out down the road. The SVC coil is much more likely to get adhered to the SVC or innominate veins, and this in turn can lead to longer procedural time, need for powered sheaths, and a higher risk of major complications. Now, there are also procedural factors to consider, which the RAPID study did a nice job of looking at. They looked at different risk factors for infection, which obviously can alter lead management and extraction down the road. Risk for infection obviously included length of procedural time, what antibiotics were chosen, whether or not you did a capsulectomy, and what anticoagulants were used. Also growing data on the use of antibiotic pouches. This study here in the New England Journal looked at 3,500 cases with and without a pocket, found that you can reduce infection rates by 40%. Pretty good using these envelopes. It was interesting though that numerically there were a higher number of endocarditis and bacteremia patients in the pocket or envelope group versus those in the control group, which the authors state as well unclear at this moment. There's also been more guidance on how and when to do extractions in the pediatric and congenital heart world. This is a nice paper written by Wilson Lamb out of Texas Children's, which is available on the ACC website. And of course, PACES released their guidelines last year, sort of outlining when to take out or consider taking out leads. However, they also stated there are gaps in our knowledge, of course. There's a lack of clarity as to when we should do prophylactic extractions, when we should consider abandoning leads versus extracting leads, and then what the impact of multiple extractions are on vascular integrity and valve function. As an example, here's a 29-year-old woman. She has congenital heart block and had leads placed 14 years ago. She had the elevated capture threshold on her ventricular lead, but still the lead was functional. And she comes in for a generator change. And the question she asked was, do you take out my leads now, or should we just wait for them to fail? This was a study done by Rob Whitehill. We crunched a lot of data and worked hard at looking at 257 patients, 393 leads. Found that 60 leads were 15% failed. And of these leads, the majority were less likely to have undergone a single generator change. The Kaplan-Meier curve showed that if leads start to fail, they start around 4 years of age, and they tend to peak around 7 to 8 years of age. So you should have a decent idea of which leads are on the way out prior to a generator change as well. All this to show that there is survival bias to our leads, meaning that if they have proven themselves to work, maybe you should just leave them alone because there's no guarantee that the next lead you put in will last the patient a long time. Of course, this has to be balanced against the risk of lead extractions on older leads down the road. So something that we do need more clarity about. Here's another example. Here's a patient with tetralogy of Fallot, has a primary prevention ICD implanted at 24 years of age, presents with an acute lead malfunction. And importantly, is a working mom and has 3 very young children. And so the question was, do you cap and abandon her ICD lead, or dual coil ICD lead, or do you extract it? I have to say the social history gets me every single time. And so for this patient, for right or wrong, I left the lead in and just put another ICD lead in next to it. Not a ton of data on this, but this paper in 2017 in Circulation looked at 6,900 patients. Median age of these patients was 78 years, so very different from the adult congenital population that we treat. 16% of the leads were extracted, the rest were capped. In unadjusted analysis, they found that those patients that had an extraction done had a lower 5-year mortality. But then when they adjusted for other risk factors, including age, sex, and device type, there is no difference in mortality rates. They did note, however, that in the lead extraction group in the multivariable analysis, they were less likely to have infections. What I noticed reading through this paper again for this talk, though, was that in patients who had an extraction, they were more likely to need a subsequent lead revision or extraction 1 to 5 years afterwards. So it sort of fits with the Whitehill paper, meaning that if you take out a lead, you're more likely to have to do something with that new lead in the near future. So again, something that has to be balanced against extraction. And of course, for congenital heart patients, sometimes there's just no ability to retain the lead, and we have to take them out. Here's somebody with DTGA and has an atrial switch, has a significant obstruction, as you can see from the venogram there, which they were symptomatic from. So the lead was taken out, and then our intervention colleagues nicely opened that up, and the patient felt much better and had their leads replaced. Similarly, here's a patient with DTGA and ascending who had a pacemaker for over 15 years. But then at 38 years of age was found to have a large baffle leak, which you can see there. So these leads had to come out with the balloon across the baffle leak to keep anything from flying across it. And then after the leads were removed, again, our interventional colleagues nicely opened this up or closed the baffle leak, this time with self-expanding stents, and then a new system was placed after. Now, one of the more recent and largest summaries of lead extraction in the adult congenital world is this one here. And Circ-EP looked at 49 patients with a mean age of 38 years. Again, quite young compared to the other extraction papers in adults without congenital heart disease. 121 leads, 92% success rate taking the leads out, no periprocedural death. The laser was required in 46%, femoral approach 8%. Lead extraction failure was related to lead age, number of prior cardiac surgeries. And importantly, they noticed that there was an increased incidence of subpulmonary AV valve injury and need for repair. This happened in 8 patients. 5 of them had atrial switches, and most of them were ICD leads. Going back to femoral extraction for a second, I do find that patients with congenital heart disease do need to have the femoral approach deployed more often. This is somewhat confirmed with this study here, or illustrated by this study here, where they found that in younger adults, there is a higher need for femoral extraction. And in their study, younger was under 40 years of age. So that fits up with a lot of our adult congenital population. The femoral approach is also required more in patients with older leads, multiple leads, or infected leads. I also find that the femoral approach is helpful for me when getting through dense adhesions, so not necessarily taking the lead out, but using it to pull on the lead, provide a better rail so that your laser or mechanical sheath can then get through the fibrosis higher up. Here's just another example, long segment obstruction on the venogram there. Grab the lead from below, create a nice tight rail, and you can follow with the laser and get through those dense adhesions. What's also important is that no access may actually not mean no access for our patients. This is again through the help of my interventional colleagues, where they can potentially open up an occluded vein for you down low so that you can increase your success rate for your procedure and also the safety of your femoral or sort of your extraction. We summarized our experience with Boston Children's recently in this paper in JACC-EP, looked at 113 patients, 162 leads in total. Median age at implant was 13 years of age, and age of extraction was 22 years of age. Found that you sort of needed to use all different types of strategies for extraction, including the laser in 44%, mechanical sheets in 1/4, we used both in 18%, and then ephemeral approach in 16%. Interestingly, what we also found was that the age at lead implant was also very important in terms of needing a complex extraction. And so leads that were implanted prior to puberty, in general, much higher or more difficult to take out. We also found a high incidence of AV valve injury, with 3 of our patients having a severe TR or flail leaflet. You know, the numbers were small for this, so we couldn't run statistics on it. Sorry, my video wasn't playing for a second. But we did find that these leads were more likely to be pacing leads, or all pacing leads, rather than ICD leads, and were in there from 13 to 32 years. Part of it might have been due to how the leads are sitting inside the heart, with a lot of loop of the leads sitting inside, or they're pulled taut up against the tricuspid valve due to patient growth. This goes along with an increasing awareness of tricuspid valve injury after lead extraction. This paper here showing that there was worsening TR in 11% of cases, and most of this is related to older lead age. It is important to note, however, that this study plus another by Coffey et al. Looked at 332 patients in total. Only 1 of those patients needed to go to surgical repair versus the 3 out of 113 patients in the Boston study that needed to have surgical intervention on their valve. So how can we make things safer? Studies have looked at using TEE, with this one looking at 940 TEEs, and found that you can use it during the procedure to look at binding sites within the veins, binding sites in the heart, and binding between the leads themselves. We found that obviously with more binding noted, you will have a more complicated procedure, and importantly, more likely to have retention of leads if they're stuck to the tricuspid valve on TEE. Use of CT scan ahead of time can also help with planning your procedure. Obviously found that if the lead's outside the vein or within the vessel wall, more likely to have a complex extraction, and then also more likely to have a longer procedure time and increased use of fluoro. So overall, I think that imaging pre-op and during the procedure can help your game plan, can help change how you counsel patients, help you mentally prepare for how long cases are going to be. And in our case, in the congenital world anyways, help you decide how best to avoid tricuspid valve injury. And that might just be leaving the lead alone rather than trying to extract it. So in summary, lead management is a lifetime of decision-making for adult congenital patients. That includes when and what to implant, and then when to extract. The ACHD population is younger at the time of lead implant and at the time of extraction, and has to deal with structural issues, access concerns, and differences in lead binding. We're more likely to have AV valve injury during extractions or after extractions in our patient population. And there should be ways to help offset this as we get to study this more. And this might be due with preoperative imaging and TEEs during the procedure itself. And although I did not touch on this, I'm well aware that there are new technologies being developed that hopefully will make this entire talk obsolete in the near future. Thank you very much.